Hello, everyone. I think we are still getting some people in, but we're already quite a lot of people. So for the sake of time, thank you so much for waiting. We were still waiting for like a couple of people to join among the presenters. So it's great to have you all here. It's quite the hot topic that we're going to touch today because it's a big introduction for a lot of countries. So very quick overview overall. We know now that, malaria is still a major cause of childhood in Africa. Of course, we are still having way too many deaths and way too many, in particular, children dying because of that. And it's been a while now that 2 vaccines have been approved by recommendation of the WHO, and there have been, of course, numerous trials. And as of now, phase 3 trials have shown more than 50% reduction of malaria cases for the year following the vaccination. We know that we have like the 4 doses, and the 4 dose it's an important 4 dose as well, and the impact of the trials so far have shown very promising impacts in the population. Of course, the vaccine itself is not just the unique solution. Also, the WHO recommends a mix of interventions, which includes, of course, the malaria vaccine, but doesn't limit itself only. We're talking about other interventions such as vector control, such as malaria surveillance, of course, and interventions such as malaria prophylaxis, of course. So at the moment, at least 30 countries in Africa are planning to introduce the vaccine, and 20 have been already approved for Gavi support for rollout. As of today, we know this is like the DHIS2 perspective. As of now, we are having the countries in orange that are still testing and developing the solution to be integrated in their platform, and the ones in blue have already integrated the malaria model in their HMIS and are already, of course, collecting data and analyzing data for the distribution of the malaria vaccine. Of course, so of intervention, and we are talking about, of course, the long-term objective of integrating all this type of information in a unique platform that allows triangulation and integrated analysis. Of course, the vaccination itself has an impact, but we need to mix the informations with other type of solutions and other type of modules when we're talking about DHIS and integrated environment. And of course, here we have like the different toolkits that could support us in the analysis of information. We have, of course, the well-known immunization toolkit, where like we can analyze the routine immunization, surveillance, stock, micro-planning, campaigns, and of course, many countries are already integrating the malaria vaccination in their EPI module. We have, of course, the malaria side of the toolkit that focuses on malaria elimination and burden reduction. Of course, there is also a part of stock management, but there is also a big focus in the products about data quality, and also a section that is fully dedicated on district dashboards that are meant for monitoring at district level, at national level, of course. We have also the side of entomology and vector control, which are, of course, core when we are talking about malaria, and in general, the interventions that can support the impact towards the burden reduction and elimination of malaria. And of course, we have like some modules for entomology that, for example, are the breeding site monitoring and the larvae seeding activities that can support the monitoring of the implementations around the entomology side of things, but of course also the side of the vector control. And of course, we're talking about IRS and ITN, both the specific activities related to these type of interventions, but also the side of the campaigns for distributions and spraying. So all of these together in an integrated environment can support the better monitoring and evaluation of the activities, but also have a positive effect because a triangulation of this type of data can add transparency and accountability of the different types of activities, but also try to have like a higher impact in the areas that are needed most, because we can then focus on areas that normally would maybe be underserved, or in general, we can have a better idea of where to more actively try to put more effort in order to reduce the burden and of malaria itself. We are going, of course, to share the type of the slides, sorry, but just so you also have in hand, we have like a bunch of resources and contacts that you could use in case you need to reach out for TA, so technical assistance for the implementation or for design or for even just like guidance and supervision. Of course, we have our HISP groups that are scattered throughout the region. But of course, if you don't have direct contact already with any of the HISP groups, we also have a general email that we normally then use to reach out to the relevant people that could support you. And of course, you could also contact me in case you have other type of questions, especially when it comes to the global side of the implementation and the side of the health content. And we have, of course, the side of the documentation where all the toolkits are explained, described, and justified in their design, of course. And you could download these metadata, and you could also like play it around in our HMIS demo environment. That is an example, of course, of what an integrated HMIS platform could look like for a country. So we definitely encourage you to interact, especially with the demo. And of course, if you have further questions, please feel free to reach out. The presenters of today, it's a variegated agenda. So we just wanted to, of course, have an overview of what countries have done so far. We know that impact will take time and various degrees of triangulation and analysis a long time. But for now, in order to use these data, we need to start to get them collected. So today we're going to focus mostly on how some countries have already started the vaccination or preparing for the rollout, and how they have approached this new addition in the EPI portfolio. So how are they implementing it in their information system, how they are integrating it in their HMIS. It could be that some countries have started in a separate instance or in a separate module, and then they will be integrating along the line in their EPI. There are different ways to approach it. We're going to hear today some best practices and some approaches that countries that have already started the vaccination and the data collection are going to present us. And we also are trying to focus also on how they are collecting and analyzing the data and what are the next steps for them in order to continue this collection and this data analysis to better monitor the implementation. So today we are going to have a presentation from Ghana that has already done quite a lot of work towards the data collection for malaria vaccination, followed by a presentation from Malawi. And then we're going to have HISP West Africa presenting on behalf of Burkina, and is going to also give us more information about best practices for design and recommendations for implementation. So countries and people that today are joining us to hear more about malaria vaccine can also have like a better idea of what it could entail when it comes to using an information system in order to collect this data and analyze this data. So without further ado, because we are having quite a lot of information to share today, I would like to bring to present Ghana. And today we're going to have Oswald from HIS Ghana to present for us. So I'll leave you the floor, and thank you so much.
Okay, thank you. Good afternoon. Can I be heard?
Yes, please.
Okay, thank you very much. My name is Oswald. I'm making this presentation on behalf of HIS Ghana. I'm a Health Information Systems Manager. So what we have been doing in Ghana since the approval of the malaria vaccine have been to try to see what we can do to integrate it into our routine immunization processes. So for the purposes of this presentation, I will be doing a quick walkthrough of what we have done so far since 2019 when we first launched the pilot of the malaria vaccine in Ghana. For the purposes of this presentation, I will share some highlights on what Ghana have done so far, and then also with regards to data management and data capture, what we are using DHIS2 to do in country. As a strategy, malaria vaccine was first launched on the 30th of April in 2019 in Ghana. And since then, deployment have been in phases covering 7 out of the 16 regions that are currently in Ghana. It was also designed to cover a number of phases. The first phase was, of course, the pilot. And subsequent to the pilot, there was an initial phase 1 deployment that covered about 42 districts. And then we had some 40 comparator districts that were not implemented, but were just being used for comparison. And subsequently, we have some 11 districts in one of the regions joining up to the number of districts that are implementing the malaria vaccine. So currently, as we speak in 2024, we are talking of about 93 districts in all across the 7 regions that we are piloting. We are dealing with an annual target of a little over 175,000 as the children under 1 that we seek to target. Now, at the beginning of the entire rollout, one of the key things that the National Expanded Program of Immunization, which is in charge of deploying immunization services within the Ghana Health Service, had a national launch and then some media engagements, and also had broad stakeholder consultations. And this was important to get the buy-in of the population and other stakeholders to ensure that we have a successful delivery of the malaria vaccine in country. The first thing that was done was to revise our national immunization schedule to try to see where we can fit in the malaria vaccine into the schedule so that it becomes routine and properly integrated into what the CHOs and the facilities already know. And so after broader consultations and looking at the schedule we have currently, what was done was to fit it in on the 6th, 7th, and 9th month for first dose, second dose, and third dose, respectively. And at the initial deployment, the 4th dose of RTSS was fixed on the 24 months, at 24 months, but upon a second review, it has now been shifted to 18 months. Part of the reason was, of course, a high defaulter rate because there was quite a longer waiting period, and also because there were not other vaccinations that were concurrently going on the 24th month. So it tend to affect the number of clients that were returning for that dose. And so there was this revision, and it was updated and reduced to 18 months to align with the meningococcal vaccine and also measles rubella too, to at least make the schedule a bit more client-friendly and all that. Now, apart from the integration with the schedule, there were also targeted messages that were designed, talking about educating the population on the availability of the vaccine and how to ensure that the uptake is encouraged. So key messages were developed from the Health Promotion Department of the service and then broadcasted across all other platforms that are available to the country for health education and promotion. When it comes to data capture, what we have done is to try to do sort of a mix method of deploying DHIS2. As many may already know, Ghana since 2012 have been using DHIS2 as a national platform for capturing routine health information data. So when we did a pilot in 2019, the first thing we did was to modify the monthly vaccination data set, which is the data set that reports all routine vaccinations for the Ghana Health Service. That was modified and data elements included for RTSS, that is the malaria vaccine, to be captured on a monthly basis. And this was aggregate in nature since 2019. So that was being done until we went into the phase 1 of the deployment. That was the 42 districts. So in 2022, we did a review. We have also been implementing a tracker for maternal and child health since 2018. And so there was enough background for us to attempt to move the efforts a bit ahead by beginning to capture transactional data for all children that were receiving the malaria vaccine. So in 2022, we also had to modify our child health tracker, which is meant to capture all routine child health vaccinations and growth promotion activities, to include data elements for capturing malaria vaccine as well. This allowed us to be able to have line listed data for all clients that or all children that were vaccinated. And then also it improved our tracking of all the individuals that were vaccinated, and subsequently our ability to be able to track AEFI if there are any using the DHIS2 platform effectively. When it comes to further adaptation, this year our plan is now to automate whatever data that we are getting from the tracker onto the HMIS aggregate data sets. This is because we have noticed that while the two are working very well, there is some disparity between what the facilities are reporting when it comes to the tracker-based implementations. And so as a way of enhancing data quality and having an integrated approach, we intend to automate the tracker-based one onto the aggregate one in this 2024. And that will mean that all facilities that are implementing the malaria vaccine will have to capture all that data transactionally using the DHIS2 tracker. These are just snapshots of some of the screens of the integration with that we did for the aggregate data set, and then also for the tracker one, where we capture details of the vaccine that is given, the batch number, and then other attributes that are relevant for line listing purposes. And this gave us the opportunity to be able to generate line listed records of all children that are vaccinated by facilities across the entire country. Still relying on functionalities within DHIS2, we have been able to build some custom dashboards that are able to allow program managers to monitor and then check performance of all the children and facilities that are rolling out this vaccine across the country. And so it's easier to monitor performances and be able to give feedback. I do know that the National API program currently is able to do some bi-weekly engagement with the facilities to try to deal with data quality issues and also encourage them to do the tracker data entry so that we can narrow the gap and the disparity between what we have on the tracker as well as the aggregate reports that are submitted manually at the end of the month. In terms of achievement, as at the end of May, when it comes to the first dose of the RTSS vaccine, we are doing just a little under 1 million, about 900,000 vaccinations have been done for dose 1, about 800,000 for dose 2, 700, also about 800,000 for dose 3, and then dose 4, which we have indicated that we are receiving some dropouts, is around 440,000 thereabout. What the initial impacts that we have observed is about a 30% reduction in hospitalized severe malaria, and of course, also reduction in all-cause mortalities. And then the increase in access to malaria prevention interventions, because as part of the process of deploying the vaccine, there is also a conscious effort in enhancing education across all the other interventions that are encountered for the prevention of malaria and reducing its burden on the country. And when it comes to acceptance, we have had quite an improvement over the years since we started the deployment. It is quite good, and this is largely due to intersectoral collaborations that we have undertaken. And then, of course, we started the pilot just around when COVID came in, but that was not a deterrent factor, as we were still able to maintain high coverages at about around 80% of the districts, achieving at least 60% coverage during the period of the pandemic. When it comes to challenges, I think we've had just 4 major challenges. One of them have to be with health worker education and training gaps, because we have issues of attrition. And so we have to continuously update and improve the knowledge of health workers to be able to continue to deploy the vaccine. Data quality issues and irregular supervision is also an issue that have been observed. And of course, I mentioned earlier the issue of the high dropouts, which we are trying to solve. With regards to trying to reduce the time waiting for the 4th dose, which is now 18 months instead of the 24 months that was initially planned. And then, of course, the availability of devices to be able to capture data transactionally is also one of the key things that we observe could pose a challenge to us. When it comes to interventions, as I mentioned, there are performance reviews that are being undertaken with the facilities that are doing the entries to be able to increase the data quality and the coverages and all that. Then there are also periodic health worker guides and interactive quizzes that are organized by the API program to increase awareness about the vaccination that is going on across the country. And there have been significant improvement when it comes to the dropout rate since we moved it from 24 months to 18 months. When it comes to a way forward, as I indicated, we will continue with the expansion, the phase 1 vaccinations in the 42 districts, and also the 40 comparators and the 11 additional ones in the Upper East region were also added in the course of the deployment to now also deploy the vaccine. And this year, starting from January, we are trying to roll out to the rest of the 168 districts so that it will become a national scale-up. I must add before I conclude that also we in Ghana have also been piloting biometric technology with Simprints Ghana in 2 of the districts. And so one of the things we are doing is that in the coming month, there will be a larger deployment in one of the regions in the Oti region, which is already piloting the malaria vaccine. And so the Simprint technology would be an add-on for the tracker model that will be used in that region to also track all vaccinations, including the malaria vaccine. And so we will be able to provide further at this as we begin that particular rollout. So to conclude, it is important to emphasize that DHIS2 as a platform with its features will be able to help us, especially in situations where we are trying out a vaccine and trying to roll it out in phases. It is important. It is an important tool to use to be able to track all the final details and the granular data that you need to be able to inform decision making and streamline your rollouts of vaccines such as the malaria vaccine. We will continue with our efforts with data quality improvement and capacity building to ensure that we are able to save lives and be able to deploy this vaccine successfully across the country. I want to acknowledge everybody in Ghana the National House of Chiefs, who are usually our leads of the traditional leaders that have helped with the stakeholder engagement to ensure that the vaccination is successful, and the various professional associations across the country, including other partners that have supported our deployment. Thank you, and over.
Thank you so much, Oswald. Brilliant presentation. There are also quite a few very relevant questions. Unfortunately, today we don't have time for a Q&A, but I would ask you, Oswald, if you could please go through the questions that have been asked so far with respect to the presentations that you've given, and if you could answer them in the chat. This way, we can also have some clarifications that are actually very relevant. So yeah, thank you so much. Next presenters is from the EPI program in Malawi. So I would like to welcome Lawrence to present the country's experience with the introduction of the malaria vaccine module.
Hello, everyone. Confirm if you're able to see my screen.
Yes, we do. Thank you.
All right. My name is Lawrence Frank Nyambalo, the Deputy Data Manager for the National EPI Malawi. So I'll be taking you through this presentation on behalf of the EPI Malawi team and HISP-UiO, that's the University of Malawi. So a bit of the background. So the Expanded Program Immunization was established by member states of the World Health Organization in May 1974, and in Malawi, it was established in 1979. Up until 10 years later, Malawi had attained the universal immunization goal when the coverage was at least 80% and above for all the children antigens, the childhood antigens. So the Malaria vaccine started in April 2019 in selected areas in 11 districts, that's 11 provinces in Malawi. So we have a 4-dose schedule starting from 5 months of age with a minimum of 4 weeks. So you have the first one, 5 months, after 4 weeks, which is a month or so, the second dose, third dose, and the fourth one is administered at 22 months of age. So nearly 2 million doses have been administered since 2019 when it was introduced in Malawi, over 660 children receiving at least 1 dose. So expansion of the malaria vaccine to areas within the 11 districts actually began in 2022. So our data, we have the initial facilities and the expansion facilities, depending on when it was introduced in 2019 and over 2022 when it was actually expanded. So we had piloted all the doses, that's malaria vaccine 1, 2, 3, and 4. And amongst the districts that were piloted, the 11 ones were Lilongwe, Alombe, Blantyre, Chikwawa, Mangochi, Nkatabe, Machinga, Nchisi, and Karonga. Pleasing to say, most of these cascaded these even in the facilities. Then how do we monitor the vaccine uptake? So all routine immunization data, including malaria vaccines, are reported through the national DHIS instance. And again, an EPI datasets and EPI indicators are configured within the national DHIS instance. So the following are the primary sources of data for malaria vaccine. So we have the under 2 register, the monitoring charts, and the monthly reporting forms. Again, we identify the stickers for malaria vaccine that were already rolled in the districts, because these were developed and were all affixed in the child health passport books for eligible children in all the implementing areas. So we also have quality data with completeness and timeliness for data reporting. DHIS2 for Malawi vaccine management. How do we go about it? So what we're trying to put here is that the introduction of the Malawi vaccines, the malaria vaccines, on the EPI routine immunization dataset in the national DHIS2 instance in 2022 had the following impact on the vaccines data management. Number one, the EPI team generally has easy access to coverage data, since coverage indicators are also configured in the national HMIS. Again, we've got also easy access to national, district, and facility level reports by the program's data management teams. Again, we also have access to inbuilt visualization tools and features. Now that we have the data embedded in DHIS2, we're able also to utilize most of the features that DHIS2 is able to provide. So we also have easy access to ready-to-use and comprehensive analytic features. So overall, I would say data management has been enhanced ever since it was actually introduced on the DHIS2. What are the milestones in adoption of the DHIS2? So beginning March 2022, we had a migration from the DVDMT. So this one is the District Vaccine Data Management tool, which was primarily used in form of Excel. We were able to keep all the data, but then upon migrating, we're able now to appreciate all data in DHIS2 for all routine immunization. Again, came June 2022, then malaria vaccine was actually configured on the national DHIS2 EPI dataset. Came December 2022, there was now the DHIS2 capacity building sessions for the EPI national data team. And 2023 until 2024, then we have data quality assessments and continuous support that's happening across the districts. This is just to give you how our reporting tool, that's the malaria vaccine data elements, how it was actually configured on DHIS2. So this is our reporting. So we've got data collected at both static and outreach facilities. So as you can see, we have for malaria vaccine 1, dose 2, 3, and 4. So now what is very important is that we are able to collect data both at static and outreach facilities. And all this data is actually aggregated using this report. Just to give you how one of the indicators is faring, that's the National Malaria Control Program percentage of the under 5 children who received the 3rd dose of malaria vaccine. As you can appreciate, we have data that was aggregated, that's January to March 2024 against January to March 2023, just to give you an appreciation how we're faring. So as you can see, these are the two trends that are only trying to give us a picture of how we're faring. So we've only taken January to March 2023 against January to March 2024. So again, this is the malaria vaccine 3 coverage for the pilot sites. As you can see, the density, you'll be able to appreciate that we're faring well in some districts. So these are the 11 districts where malaria vaccine was actually introduced. What are the DHIS2 implementation challenges, specifically for malaria vaccine? So we have capacity gaps within the EPI team on DHIS2 usage. So there are quite a lot of new health surveillance assistants that have not yet been trained. These have simply been employed, and we still need to actually provide them with a lot of skills in how they will be able to handle this data. So they have to be trained on how to use the DHIS2 to collect and analyze data from their communities. Again, data quality and documentation. So we've got also challenges with the documentation of routine immunization data, leading to missing data in immunization registers, and also on the national DHIS2 platform. Again, we've got also an IT infrastructure problem for data collection. So most of these people don't have sufficient tablets, computers, and internet access. Again, not all indicators are configured in the national DHIS2 instance. Hence, data managers are limited in their analysis. So we've got also a problem in the metadata alignment. What are some of the planned activities for Malawi? So to at least maybe respond to most of these challenges that we have, so we normally conduct DHIS2 capacity building sessions or workshops for HSS, just to make sure they are also in line with what is expected of them in terms of malaria vaccine management, data management. Again, conduct comprehensive data quality audits and assessments, and also leverage on the existing DHIS2 data tools. So we've got the DHIS2 tools audit data quality, such as the WHO data quality tool, the generic DHIS2 data quality tool. So we're using all these just to make sure that our data is actually of good quality and it's really comprehensive. So again, we're also building the DHIS2 capacity within the Ministry for the data managers to be able to also build capacity for the facilities and districts. So we have the TOTs that are always underway just to make sure that if the data managers at national level and even at ministry level are quite aware of what is expected of them to do in terms of data management, as far as malaria vaccine is concerned, they should also cascade the same trainings to the facilities and the districts. Again, we're also trying to lobby for support from partners for the procurement of the tablets, computers, and internet access. As already said, that this is also one of the challenges that we have in Malawi. Again, we're trying to conduct a comprehensive review of the EPI indicators and the metadata on the national DHIS2 instance to identify the indicators not configured in the system yet, and try to make sure that they are all configured. Again, we're trying to develop and interact and informative dashboard for malaria vaccines. Just as Ghana has ably demonstrated, Malawi is also on the way. We're also making sure that we have this dashboard just to make sure that we're able to appreciate and be able to interact with the way Malawi is faring as far as malaria vaccines are concerned. Again, we're trying to work on the integrating the national immunization registry with the national DHIS2 instance, just among the few that we've already underlined to make sure that they're actually done. So, ladies and gentlemen, this is where I end my presentation. Otherwise, thank you so much for listening. Over.
Thank you so much, Lawrence. There are still like a few questions, but I think that in some cases, some of the older questions that were posted during the Ghana presentation are also relevant for the Malawi presentation. So if you want to scroll through the chat and give some answers as well, especially when it comes to like data triangulation and data use and such, I think it would be very relevant also to have the Malawi perspective on that. So thank you so much, Lawrence, again. And finally, because we don't want to lose any time, we have Anil from HISP West Africa, who is going to give us more information about the Burkina experience and implementation, and also some best practices when it comes to design and implementation. So the floor is yours, Anil.
Can you hear me?
Yes, and we can see your screen as well. Thank you.
Yeah, thank you very much. My name is Anya Henyo for Miss West Central Africa. I have the opportunity to present the experience for Burkina Faso. The data manager have internet issue. So let me go to the presentation. This is the outline because I will talk for the beginning of the process. The pilot, new vaccine schedule, show you the data workflow, talk about the challenge, and talk about finally some activity they have planned for the next step. So for the beginning, I can say that API program, Malaria program, need to integrate malaria vaccine information for routine activity. So the country starts discussion with Gavi and other partners on that. And finally, to introduce a new vaccine in the country, you need to develop some of recommendation about that, who is powered by JTCV, who is something like a technical advisory group for vaccine in the country. they need to make some recommendation about the vaccine and the process before accepting in the country. And the other step is to have approval of this vaccine in the country because you want to have the vaccine introduction plan. And the CCAI, who is like inter-agency coordination committee in the country, need to give approval for this vaccine in the country before start also. But if you get all of them, the country creates finally the national committee who need to coordinate all activity around the new vaccine in the country. So this new committee based directly in the first region who accepts to have this vaccine in the country, but they have a lot of activity. So finally, they have the subcommittee who have the possibility to go through the introduction plan of this vaccine in the country and propose some activity, make coordination, have the meeting of other region, other partners, and so forth. So the first one is the subcommittee of planning, logistic, communication, regulation, and monitoring. So the last one have to go through all the activity they have put on the plan according to the digitalization. So they start with the pilot of malaria vaccine in the country. They just start in last February 2024 in 27 districts. So they have the possibility to receive those 1, 2, 3, 4 in the country, and there is just some information based on the information we have received in the system according the aggregate data they have collected in this system. There we have the new vaccine schedule. Because the new malaria vaccine in the country need to be added for this vaccination schedule. Also that they have worked on that, and now we have the new one who everyone have to go through and make it successful in the country. So that this is the new one they have proposed. There we have the data workflow, the committee proposed. I can say that is the first one. I think that is more about the routine data because it started with the routine data, aggregate data. So they have work, they update the AP form in the system and start collects the information directly through the those who is the national DHIS2 platform in the system. But they also have the possibility to create the tracker to collect individual data according to the malaria vaccine. So they want to use the vaccine cards who have the QR code to collect individual data, and they plan to give the possibility through web application for everyone who want to know if the children have received all the vaccine in the plan, so that they have the possibility to add it in future to give for everyone the possibility to check. They also plan to introduce the SMS to send SMS to those who have to come to receive also this vaccine system. So this is the data workflow the country proposed for to collect malaria vaccine in the country, so that to have it, they start with the review of data collection tools in the country, physical one, electric one. So they have the possibility, they have a lot of workshop on that to make sure that they can collect all the information in the country based on the new vaccine. So I think that is done. And finally, they start to collect the data based on the new form they have. So they also have they want to collect the data for IFE monitoring because they are using now OTK MSFT to collect IFE data. So they plan to make an update also on that to collect some information based on IFE. The last one is to work on the monitoring protocol so that you don't have that now, but they need to work on that because they put it in on the task. Now, this is the vaccine registration review workshop after, this is the vaccination register after the workshop, so that they have the possibility now to collect the data based on the malaria vaccine, so that the new form is okay, so that they test it on the workshop and share it with some people, and they start to reproduction the form and share it to the facility, because the facility don't have the new form who can help them to collect the real data for malaria. So that is one of the challenge of the country. But now they have the through the workshop, the last version of the form who give the possibility to everyone to collect data for malaria vaccine. But this one is Excel form. Why? Because before have the AP form in the DHIS2 national instance, they start to collect the information, but we don't have the real form in the system, so that they start using Excel to collect the first data before add it in the national instance. So they introduce this Excel form who give them the possibility to collect information about the first dose use, IFE, so forth information, so that they just use it for the first month, February, just for February. And after, they enter data directly in the national DHIS2 who is calling out those, so that they have this challenge on the beginning of the process. But now they have put here some of the challenge they have. I'm talking about the register now, because for the beginning, it was difficult to them to add something like 4 colon in the register, or 8 colon in the register, so that it was difficult to them to find a place to put the new vaccine information in the register. But finally, they find a way to add it in the register. So now it's possible. But the one challenge also they have is about the form. The new form is not directly in the facility. So when they start, they don't send the new form in the facility, so that it's difficult to the facility to collect this data. The facility want to put it maybe somewhere after reporting in Excel file. So that is one of the challenge the country puts here. And other challenge they have is about the facility. Finally, after the Excel file, they update directly the form in the national DHIS2 platform, so that those districts who did not receive the vaccine can have the possibility to put the data in the system, which is not the right information. So it's one of the challenge we put also here. And Now it's difficult to them to know all the children who receive or not all the vaccine, so that they want to work on it. Is why he proposed to introduce also the tracker who give the possibility to them to collect individual data and have information. So for those activities, the country plan is to train the district facility about the new tracker about this malaria vaccine, so that they work on it. Now they want to train all of people who want to use it, and after they will add maybe those feedback we receive after the pilot of that, and naturally make an update of this tracker in the system. The last one activity the country plan is naturally to make interoperability entre malaria tracker and aggregate data, because they want to send directly the tracker data to aggregate. Before, I think that naturally they have to make triangulation in between the two data before make it available. But this is the plan of the country about this process. Thank you very much.
Thank you so much, Anyo. We actually we have the last 5 minutes, and there was a question that in the end is pretty relevant. Although I know that for some countries might be more difficult because they might have a more data, some others might have less data. But as we also talk about an integrated system and the long-term capacity of being able to triangulate these data, there was a question from Christina that I would like to forward to all the three presenters, if they can give us a quick feedback on that, on whether the countries are reconciling the DHIS data from malaria vaccination and the data on malaria morbidity and mortality, of course, to offer then the full picture of malaria intervention. So if there is any already activity on integration and triangulation of data, not just from the EPI perspective, but also from the national malaria programs. So Lawrence, Anyo, and Oswald, if you know more about that from the countries, or if it's something that we could follow up with the countries and provide more information later on also in the community of practice. Anyo, Lawrence, Oswald?
Yeah, so I think thank you so much for that question. Lawrence here from Malawi, just to break in, just to roll the ball. So for Malawi, I wouldn't say we've got that data quite reconciled on DHIS2 on the mortalities, but then I would say there were some studies that were done. So I think they had some specific areas to also include their findings in the mortality, but that has not yet reflected in DHIS2. But then we've got that data with those studies, because these were Malawians that had keen interest just to follow up after the vaccine was actually introduced, and how it has actually helped to actually reduce the mortality and the morbidity. So we had the dissemination conference, where now that we're looking at the closing out of the interventions, of course, not to say much about if everything is ending, because the vaccine is still being administered, but then the studies that were also done, so they had some findings. So we had this conference, so we're able to appreciate how Malawi has fared, and also how the vaccine since introduction has also tried to reduce some morbidity and mortality in terms of the malaria. So I think we have that data with the studies that we actually done, but then that has not yet reflected. If anything, maybe we only appreciate to say, okay, these are the deaths from malaria, and maybe these are some of the incidences and all that. But then the proper reconciliation regarding when that was done and what has actually happened so far, maybe we might not be able to say now, but maybe with the time we'll be able to do that. But then suffice to say, we have that data with those studies that were actually done, because these were the Malawi professionals that were here just to appreciate how the vaccine has actually fared over the years. Thank you.
Very much, Lawrence. I don't know if there is like a one little note from the other presenters on these.
Yes, just to add on that there is an opportunity for Ghana to also do some analysis and matching data with our cause of death instance and also some mobility data. There is some work going on currently to have what is called the Malaria Integrated Data Repository that is also allowing us to integrate data from the other partners that are implementing the entomology instances. So there is an opportunity to do this, and we will be able to share results once it's ready.
Thank you very much, Oswald. Unfortunately, it's already the end. Time flies when you're having fun. So I would like to thank everyone for joining us today. I hope we have already received quite some nice feedback in the chat, but I really hope that this could was a good opportunity for some countries to already have an overview of what's already being implemented and the different approaches that the different countries are having already. We are definitely committed to collating more and more information as countries get to roll out and get integrating their the data in their information system alongside with their malaria modules. So we hope to be able to compile more and more of this information and share it with you both in the community of practice and also in the documentations that we normally share alongside our toolkits. So once again, one little note, if you have more questions and if you'd like to share more of your insights, you can also continue this conversation in the community of practice. So where we had, for example, the announcement for the webinar today. So feel free to also share your insights and the questions there in case they haven't been answered today here, or if you have a question tonight while you're ruminating on the presentations today. So yes, feel free to answer it there, to post it there. And once again, thank you very much for joining us. I hope this was useful, and we'll be able to provide more information later on as countries roll out. Thank you very much, and until next time, cheers.
Bye.
Bye.